Medurstand-Understanding Medicine.
I'm Professor Azizur Rahman, and in the first part of this lecture, we discussed some basic principles about insulins, various types and various profiles. And today we are going to discuss the usage of insulin in various patients, and I will also explain how to make appropriate adjustment and insulin dosage to get their glucose level to the desired level. Now, insulin comes in various forms, and this one is traditional vial, which contains 1000 international units of insulin, and this is called U100 because 1 cc has 100 units. And this is the syringe which is specially designed for insulin administration, and all these numbers they indicate insulin units. For example, if you want to inject 50 international units of insulin, you just fill the insulin up to this level, and every time you will have to use a new syringe, and every time you remove this cap and remove this cap, I think you remove this once, and then every time you have to puncture and take some insulin from this is okay, this is perfect, but some people they do not like to go through this hassle, so there are some new technologies which provide more convenience, but this is, as far as insulin is concerned, this is okay. So this is a regular human insulin, and you all know this insulin is relatively slow to act. Once injected subcutaneously, it will take about 30 minutes before it starts acting, because it makes hexamers, and from the hexamers are converted into monomers and absorbed slowly. Another brand is Actrapid. This is very similar. You could use either one. Both are same insulins, human recombinant insulins, and both come from two companies. They're both very, very reliable companies. So you could use either one. Now, insulin types based on injection techniques. Instead of syringe, we could use pens. Patient always perceives pen as more friendly and easy, and we should take advantage of that situation. And if patient is reluctant to accept syringes, I think we should offer them pen. This pen has got insulin filled in it. There are two types of pen, actually, disposable and the one which has to be loaded with cartridge. This one I think is the one with cartridge, but very easily you just dial the dose from here, and very fine needle you inject in the subcutaneous tissue. So this is convenient, I think, and also little hassle free, but this would of course be little expensive than syringes, but still manageable. Now this is the best, perhaps you would see, this is the best technique of injecting insulin. Expensive, this is the insulin pump, and insulin cartridge is loaded in it here, and this always use the regular insulin or rapid acting insulin analogues. It does not use basal insulins because it is actually continuously infused, so there is no point in giving basal insulins here. And this is the cannula. It injects insulin into the subcutaneous tissue at a very, very slow rate. What rate? That is guided by this glucose sensor. And there is there's a small needle in there. It senses glucose from the subcutaneous tissue, and then based on glucose level, it sends signal to this device how much insulin to be injected. Now, if somebody is heading toward hypoglycemia, this would not only generate alarm, it will also shut down for the delivery for insulin. And if patient has got hyperglycemia, again it will generate an alarm and will increase insulin delivery. And there is also option of manually overriding this mechanism, and if the sugar is too high, then of course by manual buttons you can inject a bolus. So it sounds great, but the problem is that these devices are expensive. I think we have to consider the ground reality. In our population, majority of the people will not be able to afford this. Of course, I always say if there is a person who need it, and who needs it and who can afford, I think he should not be deprived of these modern technologies, because this would then translate in better glycemic controls, lesser hypoglycemia, and better outcomes. Now, what kind of insulin is to be used? I think you would agree that if we can reproduce the normal glucose pattern, that will be great. So to do that, we first have to understand the normal glucose pattern. This is the physiological glucose level over 24 hours. Now, there are this number one, we have a fixed glucose level because we need glucose all the time. If glucose drops below this level, there could be serious problem, and especially there could be damage to the brain. So nature has made a system that there is some insulin, some glucose all the time. Once we go to this level, insulin mechanism is shut down and glucagon mechanism is activated so that a minimum level of glucose is maintained. Now, whenever we eat, of course, it depends on what we eat and what is the composition of that meal. There is excursion in that glucose. Now, although our alpha cells, beta cells, they do try to prevent these excursions. Despite that, we do have some excretion after meal. So this is normal physiological pattern. So it is normal to have increment in glucose level following a meal. Now, what is the insulin? How does insulin behave in physiologically? In the same pattern, there is a certain amount of insulin which is there all the time, and then we need additional insulin boluses, which is actually produced by the beta cells. So whenever we eat, glucose tends to rise, and that glucose stimulates beta cell, and GLP also help this mechanism, and the insulin level increases after the meal. So I think you just keep this thing in mind, this picture in mind, that we have to reproduce this type of state when we replace insulin. Indications of insulin, I think all type 1 diabetes patients should be started on insulin, because if you do not do that, they would go into DKA and would die. Any patient with metabolic coma, even type 2 diabetic patient can develop DKA and hyperglycemic hyperosmolar state. So any patient who present with metabolic coma, they should be given insulin. And then type 2 diabetes patient, when oral and other injectable fail to bring HbA1c to less than 7. That is one indication, I think the strongest indication. And then there are some special situations like type 2 diabetes patient with severe hyperglycemia at the time of diagnosis. Somebody comes with sugar of like 500, 400, with the recent weight loss, polyuria, polydipsia, too worried, and I think it makes very good sense to start insulin with oral agents. Now, this is a situation where our intention is uh, to give him oral agents, and I'm sure in most situations oral will work, but we have started with insulin to have immediate effect, because oral will take several weeks since patient is at the verge of complication. And I think we need to explain to the patient that we are going to use insulin for a short period, and I have seen in my experience after 2 to 3 to 4 weeks, mostly we are able to withdraw this insulin if used with this specific intention. Then there's some specific situation, pregnancy, surgery, or trauma. I think even if patient is controlled on oral, in these situations, we temporarily switch to insulins. Now, next few slides will be on type 2 diabetes when oral other injectable fail, because majority of the patients who need insulin, they actually fall in this group. Uh, how to start insulin, various types of insulins, initiation strategies in type 2. which insulin to start. There are various societies, American Diabetes Association and European Association for the Study of Diabetes jointly recommend that best insulin to start with is basal insulin. Why? Because basal insulin is just once a day and most convenient, and I think patient acceptance is high. IDF, which is International Diabetes Federation, Diabetes Australia, Canadian Diabetes Association, American Association of Clinical Endocrinologists, these are also big societies. They say basal is good, but you could also start with pre-mix. I have already explained pre-mix are actually combination of rapid acting or short acting with intermediate acting. These will be injected twice a day, and this is once a day. So according to these societies, basal or premix, either one is acceptable. The NICE guidelines, the British guidelines, they say that basal or premix, basal or bolus, basal or premix or basal plus bolus. These are three regimens, either one is acceptable. Basal bolus means that you give one basal once a day, and then depending on the number of meals patient take, we give additional boluses of short acting or rapid acting with meals. So if patient eats twice a day, there will be 2 boluses, and if patient eats 3 times a day, then there will be 3 boluses. Now this is the typical approach. This is like if somebody's HbA1c is more than 7 despite 2 to 3 oral agents or GLP-1 receptor agonists, you need to consider insulin. This is, I think, that most commonly followed pathway. We start with basal insulin. If that doesn't work, that might bring down the fasting sugar but may not control the postprandial, then we might actually consider premixed, or we might consider the basal once a day and then 3 boluses. But there is no binding. I think depending upon patient's glucose profile and depending upon your preferences, I think either could be the starting point. We could actually start with this one, we could start with this one or this one. But I said mostly we go this way: basal insulin, premix, and then basal bolus therapy. Now, comparison of various insulin regimens, just basal, premix, and basal boluses. These were the 3 options I gave you in the last slide. So let me just give you some of the differences. Now, basal must be used early. I think before beta cells completely fail, because basal insulin will address the fasting sugar. You will still need viable beta cell to control postprandial glucose. It does not cover prandial sugar. Some secretagogues is usually necessary to cover the postprandial phase. In my first lecture, I mentioned what are the secretagogues. Then premix, convenient twice a day. Premix in the same vial or same pen. Patient will have to inject only twice with meal. If it is premix analog, within 10 minutes of the meal. If it is pre-mix conventional human insulin, then 30 minutes before meal. But it covers both fasting and prandial sugar. Then there is basal bolus. Best possible glycemic control, at least theoretically, best possible glycemic control is with this one, because you inject basal insulin once a day and you adjust the dosage of basal insulin based on fasting glucose. And it is very demanding, and you need 4 pricks for the insulin injection and maybe 3-4 pricks for glucose testing also. So I think this is very demanding, but theoretically perhaps the best. Now this is the type of pattern we want to develop. Now you remember this is the physiological state, and let's see if we can reproduce with insulin. Now this is the NPH. It should be like this. So this NPH is no way near the normal pattern of insulin. Whereas insulin Glargine or insulin Detemir or insulin Degludec is quite close. So I think technically these insulins are better as basal insulins. Now let's take the example of human short acting. You can see the onset of action is late as compared to normal, and three times they start late and then the function also persists till late. This, for example, provides an opportunity of hypoglycemia in this one. Now compared to short acting human insulin, if you use rapid acting insulin analogues, it will, I think, will be more like normal insulin curve. So I think we can make a case that when we talk about prandial insulin, analogues are better than short acting, and when we talk about the basal insulin, the insulin analogues Glargine, Detemir and Degludec is better than NPH. But of course, in any treatment, first you have to consider the doability. Patient has to be patient has to afford the medicine. So I think if patient cannot afford analogs, then conventional insulins are very good, provided you understand their limitations. How to adjust the dosage of insulin basal? Uh, I think I know it's getting very long, it's taking long time, but I have to cover this. You can split this video into two and you can pause and watch again. Starting dose is like approximately 10 units. It is weight based. You could start with as small dose as 10 units. You could start higher dose. I have many times started with 25 units, 30 units, depending upon patient's fasting and postprandial sugar or patient A1C. Then inject once daily at the same time, irrespective of the meal. Now, since they do not start acting, they do not start lowering glucose immediately, so they do not have to be taken with meal, can be taken anytime, whatever time is convenient to that patient. I normally prefer the patient to inject at night, but it can be taken in the morning also. Uh, and you could, it has to be the same time every day. With most insulin you could actually inject 1 to 3 hours before or after the meal time. Monitor blood sugar fasting daily. Patient injects insulin at night, but you monitor fasting sugar daily and then take average of 3 days. So this is the plan which is going to take some time before you can get to the goal. So every 3 days, based on daily fasting sugar, you calculate the average, and if your average is above 110, you make an increment of 2 units. Now this is of course again can be changed. If somebody's starting glucose is very high, you could make an increment of 5 units, and once you are getting closer to the goal, then you can make smaller increments. And the aim is to get a profile like this, flat 24 hours same. And once you are at your goal of about 110, then you can continue the same dosage for indefinite period of time. Of course, it would need periodic readjustment, but at least for now you have found the right dose for that particular patient. Now we have fixed the fasting. We need to fix fasting first with Glargine, Detemir, Degludec. We have fixed the fasting sugar at 110 or around 110. Now this is how to adjust the dose of insulin short acting. Human Humulin R or Actrapid HM. Starting dose 5 units 3 times a day, twice or thrice if patient takes 2 meals, twice if patient takes 3 meals, thrice. Inject half an hour before meal because these take 30 minutes before they start appearing in blood. So I think half an hour before meal. Monitor blood sugar before the next meal. So patient injects before breakfast, patient inject before lunch and also dinner. So when we want to adjust the pre-breakfast insulin, we would based on the pre-lunch sugar. Increase the dose of 2 units of the preceding dose of insulin every 3 days. Now let me explain this again. Suppose you injected 5 units before breakfast, and on 3 consecutive days you notice that blood sugar before lunch was like 180, 190, 200. That is much higher than what you expect. So then after 3 days you increase the morning dose by 2 units from 5 to move to 7, like this. Continue up titration till at goal, which is around 130, and then once you have achieved this goal, you continue the same dosage. And see, this picture shows that insulin is to be injected half an hour before meal. How to adjust the dosage of insulin: rapid acting, Lispro, aspart, novorapid glucosine, exactly the same way, except that you inject it 10 minutes before meal. I think otherwise it is exactly the same. You just inject and within 10 minutes you eat. So it is the same. How to adjust the dosage of premix. Now this is important because in our country, majority of the patients who are insulin, they are using premix insulin because it is convenient. So I think we have to consider premix insulin is of two types: Humulin 70/30 and Mixta-30. These are based on human insulin, or we have Humalog mix 25 and 50, and we have no mix 30. These are actually based on analogues. So either way, we give combination in the morning and evening. Starting dose, this is just an idea, 24 morning and 16 at night. I mean, this is usually the range I normally start. So 24 morning and 16. Why not the same dose morning and evening? Because after dinner we sleep and we do not take another meal, whereas in the morning after breakfast we take another meal. We do not, in this regimen it is twice a day, we do not inject any insulin before lunch, so that is why the morning dose has to be a little higher than the night dose. Inject half an hour before meal, monitor blood sugar before breakfast and before dinner. Increase the dose of 3 units in the morning and 2 units before dinner every 3 days till you achieve your goal of blood sugar of less than 130. Before meal, I think I would set a goal of pre-dinner at 130 and goal of fasting at 110. But problem with this pre-mix insulin is that if you your intention is to increase that long acting component, but short acting will also be increased. So I think best glycemic control is not actually possible with this combination. It is convenient. Make right decision and choose right insulin. But we know that sometimes making the right decisions can be difficult. Now this guy has got very difficult decision to make. So in real life, I think that also can happen. Insulin, how to store and carry. Some of the practical points: store in a refrigerator in the door pocket, never in a freezer, can be kept at room temperature for limited hours. Only 1% reduction in efficacy per day, provided not exposed to direct sun or heat. Insulin pen may also be kept in the refrigerator despite manufacturer's advice to the contrary. Because in our country temperature is very high. During the transportation, they can be carried in a bag and put in the covered area in the car, like in the glove box or in the bag, and should not be exposed to direct sun for extended period of time. Now these are some of the example: insulin vials, insulin pen, and these are the sites where you can inject. I think just around this little part of what do you call it, navel, this should be avoided. I think we can inject on various parts and rotate it. You could also inject on thighs and also the arms, but best is perhaps abdomen. Very convenient to inject, and you can expect more uniform insulin absorption from the abdominal wall. Summary. So finally, we're coming to the end of this presentation. Summary. We should talk about insulin early at the time of first counseling, because when we actually need insulin, patients should be already anticipating. Insulin is the most potent glucose lowering therapy so far we know. Early insulinization offers best chance of glycemic control when orals are failing. Before you wait for orals to completely fail and patient stays in a hyperglycemic state for a long time, I think before they fail, after 2 agents, one should start using insulin. This is early insulinization. Start with basal or pre-mix insulin. Analogues are at least technically better. Less chances of hypoglycemias 3-4 hours after meal, and less chances of hyperglycemia immediately after meal. That translates into better control, because if there is no hypos, then patient is more likely to up titrate and take proper dose. There's a lot of room for improvisation according to individuals' eating pattern and lifestyle. No one size fits all. I think every patient poses a different challenge, so you could actually improvise a insulin regimen for that particular patient. And in most situations, other glucose lowering therapies, metformin, sulfonylureas, and SGLT2 inhibitors are continued when insulin is started, because they have their unique benefits. So typically they are continued for their own unique benefits and also for glucose lowering effect, because some of these agents, they work through an independent mechanism. Metformin and SGLT2 inhibitors, they have entirely different mechanism of action. This was covered in my first 2 lectures. Now get A1C to goal, whatever it may take. Lifestyle changes, oral agents, non-insulin injectable, and insulin, get them to the goal. So this was, ladies and gentlemen, my third lecture focusing on insulin, and in the first 3 lectures we have actually covered various strategies to control hyperglycemia, which is the main metabolic abnormality in type 2 diabetes. But I mentioned in my introduction of this disease that this is a very complex disease. There are many associated abnormalities. Unless you address them, you cannot get away with all the complication of atherosclerotic cardiovascular disease. So we need, most type 2 diabetic patients need additional therapy. So in my fourth lecture in the series, fourth and the last lecture in the management of type 2 diabetes, I will discuss the role of those additional therapies, which are actually important, because our ultimate goal is not only to control just glucose, but ultimate goal is to prevent complications. With that, I'd like to thank everyone who has bared with me, who has watched this video, and I really look forward to see you in my next video. Thank you very much. And this was Professor Azizur Rahman from Medurstand.